Assalamualaikum doctors. In this video, I am discussing about Addison's disease history. So, Addison's disease history, the chief complaints can be child with vomiting and hyperpigmentations, or as a part of panhypopituitarism, craniopharyngioma. So, after any surgery, child who is vomiting, like suppose so much vomiting or loose motions, then dehydrated comes. Diabetic child presented with recurrent hypoglycemia despite good control. Child with hypothyroidism and after starting levothyroxine developed fainting attacks. Child with mood change, behavioral and neurological symptoms and abdominal pain. So these are the features: mood change, behavioral, neurological symptoms and abdominal pain, severe abdominal pain like the image. So how can we take the history? OCD, onset, course and duration. Is that anything make it better or worse? All the complaints present with together or one by one. Then if fainting, then a special character, specific any posture, before, what, during and after. Before what happened, during, can you describe how it happened, after how abated and admitted or not. If vomiting at specific time related to food, color, content, blood, dehydrations, every time treated in hospital with IV fluids. And the idea about the amount, frequency, color, odor, blood, mucus, undigested food, signs of any fluid depletion and admitted or not. Then about the weight loss, appetite loses evidence. Ali, that is growth chart, or clothes become looser. General and fever, fatigue, decreased activity and sleepiness. Another concern, any dysmorphic features, any chronic illness, especially autoimmune disease. May they have autoimmune condition present like thyroid, diabetes, bronchial asthma. These are hypothyroidism. These are can be present. So again, I'm chief complaints analysis, OCD, increase, decrease, all together or one by one. If fainting complaint, any special character, specific posture, before, during and after, how abated, admitted or not. Vomiting at specific time related to food, color, content, blood, dehydrations, every time treated in hospital with IV fluid. Diarrhea, amount, frequency, color, odor, blood, mucus, undigested food, signs of fluid depletion and admitted or not. Weight loss, about the appetite losses evidence, growth chart or clothes become looser. General fever, fatigue, decreased activity and sleepiness. Other concerns are any dysmorphic features, chronic any disease, especially the autoimmune disease. Then about the systemic review. GIT, we have tummy size, tummy pain, poo. If not, the complaints on oral and anal soreness, and tongue and mouth pigmentation. Remember, tongue and mouth pigmentation. This is very important. We ask that pigmentation present in the body. Where the pigmentation? Tongue and mouth pigmentation. Nutrition, we ask number of meals, center in each meal and salt craving. Addison's disease have salt craving, remember. CNS, increase ICP in secondary to adrenal insufficiency, weakness, fits, bugs, trauma, hemorrhage, shunt, unusual any behavior, unusual movement, depression, loss of interest to something was enjoyable before in adrenoleukodystrophy. So depressions like loss of interest to something was enjoyable before in adrenoleukodystrophy, concern about vision and hearing. Then about the CVS, heart racing, awareness of heartbeat, blood pressure, fainting when standing up from the sitting, postural any hypotension present or not. Chest, about the recurrent bugs, noisy breathing, chest sound, chronic cough, sputum and night sweating. Urinary, about the pee, color, pain, amount and if more at night than before, color change or concern about private parts, pigmentation or unusual shape. Then endocrine, about the thyroid, Cushing, salt crisis, numbness and blood sugar. MSK, about the skin spots, bruises, vitiligo, hyperpigmentation in the scars or sun exposed areas, swollen glands, lumps, bone pain, joint swelling, hair loss, abnormal hair distribution and nail changes. Hematology, about the pallor, bruising, bleeding and recurrent bugs. Past history as usual, 5T IOA, exposure to radiation, bug in brain, travel to areas where TB is endemic or contact with a diseased persons, recent IV line, drugs intake, easy access to hospital, puberty in details, perinatal history, neonatal hypoglycemia, development, adrenoleukodystrophy, and growth chart. LRG, vaccination missed any shots, COVID vaccine, family history of autoimmune disease, consanguinity, home modification, old pipes, old pains, social and psychological, school attendance, absence, bullying, and why due to pigmentation. History of anorexia nervosa need to exclude. Are you avoiding food, conscious about figure? So weight loss history, a teenager, we have to ask that. Are you satisfied about your weight or any concern about you want to lose weight? Okay. So DD of adrenal insufficiency, it is acute and chronic. Acute case is not pigmentation. They have sudden stoppage of steroid history we find, congenital adrenal hyperplasia, trauma, severe hypotension, sepsis and meningococcemia. So acute are these. Chronic pigmentation are autoimmune Addison like tuberculosis, trauma, pituitary or hypothalamic, intra-abdominal surgery, pituitary or hypothalamic surgery, radiation abdomen or pituitary, and adrenoleukodystrophy. DD of oral pigmentation are Addison, Pearce-Jaggard, and drug-induced OCP, chemotherapy, doxycycline, zidovudine. So remember when we asked that pigmentation, where actually describe the pigmentation oral around the mouth, that is Addison's, either Pearce-Jaggard syndrome, either these are all drug-induced. So causes of Addison's disease are autoimmune, post-tuberculous, the most common cause worldwide. Infections, HIV, sepsis, adrenal hemorrhage, amyloidosis, post-surgical removal of adrenals, and adrenoleukodystrophy. So surgery history can be present. Adrenoleukodystrophy, what is that? It is a type of hereditary genetic condition that damage the membrane myelin sheet that insert the nerve cells in your brain. And adrenoleukodystrophy. So, okay, these are. So Addison disease, so what are the clinical features? By that we understand that adrenal glands not produce the sufficient steroid hormones. So oral skin pigmentation we find, low blood pressure, weakness and weight loss. GIT we find nausea, diarrhea, vomiting, constipation and abdominal pain, skin vitiligo. Adrenal crisis also sometimes develop. Adrenal crisis, what happen? Fever, syncopes, convulsions, hypoglycemia, hyponatremia, severe vomiting and diarrhea. Okay. So it was come how I am telling DD anorexia nervosa, carcinoma and hypothyroidism, pregnancy. Okay. So Addison's disease exam asked how it come. Nadine is a 16-year-old girl who come with abdominal pain and vomiting for 4 days. The symptoms started 3 months ago with fatigability and skin darkness, but blood pressure is normal and RBS is normal. No investigation done, no treatment given. Don't forget to ask about the autoimmuno package in systemic review and possibility of pregnancy. Okay. In adolescent, history of examiner put pregnancy as DD. So always they put DD, so menstruation history will take. Can it be Addisonian crisis? Yes, because Nadine did not receive any treatment and not following up. DD, Addison's disease, adrenoleukodystrophy and pregnancy. Examine wanted acute and chronic DD. So I tell you acute and chronic DD already. Investigation acute and chronic. Okay, then management I will tell the next video. Thank you.